Okay, guys, in this lecture, actually, occlusion is a very, very vast subject, but just to give you an idea about the occlusion, or even if you are appearing in the exam and you want some revision regarding some concepts of the occlusion, so that is why this lecture is over here. Occlusion and malocclusion. Occlusion is defined as the way teeth meet when the lower jaw, that is mandible, and the upper jaw, that is maxilla, they come together. It is how the teeth they contact in any type of functional relationship. Malocclusion of the teeth is a misalignment problem that can lead to serious oral health complications. Edward Engel, if you remember, we have discussed about Edward Engel in one of our lectures, that he was the father of the modern orthodontics, and he gave the concept of normal occlusion, class 1 occlusion, class 2 occlusion, and class 3 occlusion. And we have also discussed that being the molar relationship class 1, his classification is based on the first permanent molars. Relationship of the first permanent molars, upper and lower, class 1, class 2, and class 3. We are not going into the detail. And then, of course, the class 2, it has two divisions, the class 2 div 1 and class 2 div 2, depending upon the incisal relationship, whether the incisors are proclined or they are retroclined. Occlusion is the contact of opposing surface of teeth of two jaws. Centric relation means untranslated hinge position of the mandible to maxilla. And centric occlusion, that is the occlusion of the teeth as the mandible closes in the centric relation. This is the reference position from which all the other horizontal positions, we call it eccentric occlusion. Disocclusion, it is contacting of a designated groups of teeth in order to disallow contact of any other groups of teeth. So those teeth which are not in contact, they would be in disocclusion. During lateral movement, the orbiting, which is non-working condyle, it revolves in the orbit around the rotational center of the opposite, like in the center of the opposite rotating, that is working condyle. For example, during right lateral movement, right condyle is working condyle or rotating condyle, and the left condyle is orbiting or non-working condyle. And same is true if we are talking about the opposite side, when it becomes the opposite side. Disocclusion, the anterior guidance and the posterior disocclusion. Now, just to bring your lower incisors and your upper incisors together, and you will feel your posterior teeth are not in contact. You have made a protrusive movement, a protrusive contact, an edge-to-edge contact of your upper and lower incisors and your posterior teeth. They are separated, they are in disocclusion. Similarly, when there will be lateral movement, there would be two possibilities. One is the possibility of canine guidance, and the other one is possibility of group function. The side you are moving your mandible, or the side where your condyle is moving toward, bringing your mandible outside, that would be considered as the working side. And the opposite side is considered as the non-working side or orbiting side. The working side condyle is also known as rotating condyle. Why rotating? It is just rotating in its orbit, whereas non-working condyle is orbiting. It is orbiting. So it does not mean that the non-working condyle is not working. It even has to work more. It will be coming out of its glenoid fossa. It will be moving forward, and then it will be moving in the mesiotrusive movement. The working side will be going on the laterotrusive, and the non-working side will be going into the mediotrusive. Why we call it working side? Because the teeth are in contact. That is why it is known as working side. The teeth are not in contact on the non-working side. And there are two possibilities, as I have already mentioned, the canine guidance or the group function. Canine guidance means on the working side, upper and lower canine, they come in contact and rest of the dentition is out of occlusion. Whereas in group function, the canine as well as all the posterior teeth on the working side, they will be in contact, and all other teeth will be, including the non-working side teeth, they will be out of occlusion. They won't be in contact. That is group function. Both these situations are considered as normal for the natural dentition. As I told you about the rotating condyle and the orbiting condyle, the rotating condyle is the working condyle and orbiting condyle is the non-working condyle, also known as balancing side condyle. The non-working side is also called as the balancing side. Now, which inclines we have to see for the rotating path? If you look at the teeth, the buccal cusps and the lingual cusps. Buccal cusp, it has two inclines. The outer incline, that is the buccal incline of the buccal cusp, and the lingual incline of the buccal cusp. Similarly, lingual cusp, it has lingual incline of the lingual cusp and the buccal incline of the lingual cusp. So far, so good. Everybody is okay. Yes, no, maybe. The working side inclines, which we need to be addressing during any problem, these are the upper buccal cusps lingual inclines and lower lingual cusps buccal inclines. Whereas in the orbiting side or orbiting condyle side or the balancing side, the balancing inclines will be upper lingual cusp. This is the lingual cusp of the balancing side. So lingual cusps buccal incline. This is the lingual incline of the lingual cusp. This is the buccal incline of the lingual cusp. So upper lingual cusp buccal incline and lower. This is the buccal cusp of the mandible or like buccal cusp of the lower on the working side. So lower buccal cusp, its lingual incline is important. Premature contact can occur over here during the movement. Working side is this one. Mandible is moving in this side. It is going in laterotrusive on this side. And it is going in mediotrusive on this side. So far, so good. Everybody is okay. Yes, no, maybe. As I have already mentioned about the working condyle and non-working condyle, this is the working condyle which is rotating in its glenoid fossa, but the non-working condyle, it is not only coming out of the glenoid fossa, but also moving in a medial position. And there are various other things which at the moment here we are not discussing. We have already discussed in our lecture about the shift when the non-working condyle moves from its rest position to this position on the mediotrusive. It could be immediate side shift, it could be recurrent side shift, it could be progressive side shift, but it has to move. Immediate side shift is that movement which immediately before any other movement, the condyle moves in a medial position. That is immediate side shift. And whenever there is an interference present, no matter it is natural dentition or it is some restorative procedure you have done, then the Non-working side interferences, they will be having more influence if the immediate side shift in that person is present. Remember that. Everybody is okay? Yes, no, maybe. That is why it is not a very, you can say, good thing to restore or make a crown or a bridge on just plain line articulator. You have to use the adjustable articulator in order to avoid this type of interferences. Terms which are related to occlusion, maximum intercuspation, it is the most closed complete interdigitation of the mandibular and maxillary teeth irrespective of the condyle centricity. It does not mean that the condyles will be in centric place or centric position. Protrusion, it is the forward movement of the mandible. Retrusion is the backward movement of the mandible. Transtrusion is the total lateral translation or side shift of the mandible. Mediotrusion is the lateral movement towards midline of head of the orbiting or non-working condyle towards the medial side or mediotrusion. Laterotrusion is the lateral movement that is away from the midline of working condyle or rotating condyle. Surtrusion is the upward movement of working condyle from its centric position. Detrusion is the downward movement of either condyle from its centric position. Hinge axis is that imaginary line which is connecting the rotational center of one condyle and around which mandible makes opening and closing rotational movement. Only opening and closing, that is the hinge axis. This is the canine guidance, as I told you earlier, one of the ideal situations in the ideal occlusion. Canine guidance. Upper and lower canines, they are in contact and all other teeth are out of occlusion. Or group function on the working side, canine and all the posterior teeth, they are in contact on the working side and rest of the dentition is out of occlusion. Ideal occlusion. What is an ideal occlusion? An ideal occlusion should provide comfort and function in a predictable way. Ideal occlusion at the tooth level, cusp tip to fossa or cusp to marginal ridge contact, that is no incline contact. Just imagine if there will be an incline contact. This is the upper tooth, this is the lower tooth, and they are having incline contact. What is going to happen? It is not going to be stable. So in order to achieve the stability, it will move either this way or this way. We know that mandible is movable, whereas maxilla is a fixed entity. So mandible will move, and that is why we call it mandibular shift. Everybody is good? Yes, no, maybe. This position is, when the teeth are coming in contact like this is not an ideal thing. It is not an ideal situation. Ideal occlusion will be something like this. Ideal occlusion at the articulatory system level, posterior stability, anterior guidance, and lack of posterior interference. Means posteriorly teeth will be stable as I showed you. Then there should be an anterior guidance. What is anterior guidance? Anterior guidance is anterior teeth, they should be having sufficient overlap both horizontally and vertically. Both horizontally and vertically. That is anterior guidance. Ideal occlusion at the patient's level within the adaptability of the rest of the article means patient's muscles, ligaments, joints, everything would be adapting to the situation, to the occlusion. That is an ideal occlusion considered at the patient's level. Features of ideal occlusion: anterior guidance. In lateral excursion of the mandible, working side contacts, preferably on the canines, they disocclude or separate the non-working teeth instantly. In protrusive excursions, anterior tooth contacts will disocclude the posterior teeth. I have just showed you both the things. Like in protrusive guidance, posterior teeth are disoccluded. In canine guidance, all other teeth are disoccluded. Posterior stability: enough posterior teeth in each arch will, with solid and stable contacts in appropriate positions to evenly distribute loads and to allow the mandible to close in a reproducible centric occlusion. Posterior teeth contact more heavily as compared to anterior teeth, and it is enhanced by having taller cusps and deeper fossae. It maintains the teeth position. Centric occlusion or the intercuspal position is easily reproduced. Increased masticatory function will be in this situation. Signs of lack of the posterior stability will be drifting of the teeth. Phreamitis. Phreamitis is a condition when teeth are in occlusion and you touch with your finger, you feel that teeth are slightly mobile. That is phreamitis, and phreamitis is a sign of occlusal trauma or occlusal instability. Fractured restorations, mobility, and the wear and tear of the occlusal surface or incisal surfaces of the teeth. Here we can see lack of posterior stability. It will lead to wear and tear, fractured restorations, fractured tooth even, etc., etc. Absence of posterior interference should be there. When the mandible will be moving in this way, we can see that there would be some interferences over here. They should not be present. Non-working side. And remember that interferences on the non-working side are having more deleterious effect as compared to interferences on the working side. Features of the ideal occlusion, we are discussing. Centric occlusion is achieved at the centric relation position. Means there must not be any shift from centric relation to centric occlusion. When in centric relation, there will be freeway space, but when the person will be bringing the teeth together without any shift, the freeway space is going to be covered and the teeth will be coming in contact with each other. No more freeway space. Occlusal loads are axially transmitted through the teeth, means whatever the forces they are going to be from different angles, they all will be resolved in a resultant vector and it will be axially transmitted along the long axis of the tooth. Organization of occlusion. There are three recognized concepts that describe how teeth should contact in various mandibular positions. The bilateral balanced occlusion, which we try to achieve in our complete dentures, or long span partial dentures, removable partial dentures. Unilateral balanced occlusion, that is group function, and that is present both, like it is present in the, it could be present in the permanent dentition or natural dentition, or it could be produced in the fixed prosthodontics, like in bridges or the fixed partial dentures. Mutually protected occlusion, that is the canine protected occlusion, where the canine, they come in contact on the working side and rest of the dentition is out of occlusion. When we see mutually protected occlusion, it means that when in centric occlusion or in maximum intercuspal position, posterior teeth will be interdigitating and anterior teeth, they will be slightly out of occlusion. There will be slight gap between the anterior upper and lower teeth, so that there won't be any problem on the anterior teeth. They are not going to have some excessive load on it. Similarly, when you will bringing the teeth in protrusive or in lateral excursion, so in protrusive, what is going to happen? The incisors, they are going to be in contact and posterior teeth will be disoccluded. And in lateral movement, there will be canine guidance, means upper and lower canine will be coming in contact and rest of the teeth will be out of occlusion. Is it clear to everyone? Yes, no, maybe. So far, so good. So over here, we are done with this lecture.